Chauhan sir, and our West Bengal Orthopedics President Dr. Amyo Kumar Bera sir, along with Dr. Subroto Basu sir, who is a veteran Ilizarov surgeon from West Bengal. So I will ask Dr. Hoda sir to sir. You can unmute yourself.
Sorry. We request our President Jain sir to initiate the program. Jain sir, over to you, sir.
Okay.
Jain, you start.
So 2 words from you because this is the first webinar from the new team. So we request our new President and Secretary to say a few words before we start.
Okay,
Jain,
sure.
sir.
Okay.
Jain, sir.
Okay.
Yes, Shamsul, you want me to speak?
Yes, sir, please.
Yes.
Okay. I welcome Dr. Daniele Pili for this first webinar we are having, online webinar. And this would give us insight and his way of treating the gap non-unions. I hope this webinar becomes a success for all listeners as well as viewers. Over to you, Shamsul, for further proceedings.
Thanks for the golden words, sir. I request now our Secretary, Dr. Amar, to say a few words. Dr. Amar, are you there?
Yeah. Yes, sir.
Please.
Good evening, sir. I welcome Dr. Pili in this talk on massive means ELISA and bone loss, and we'll be very happy to hear from him regarding the insights on bone loss and his way and how he is dealing with this injury. Thank you, sir.
Okay, so
I request Joydeep to introduce Dr. Pili first.
Yeah. So Dr. Pili, Daniele Pili, he is an orthopedic surgeon specialized in limb reconstruction from Manjoli Hospital, Lecco, Italy. He completed his training in trauma and orthopedic surgery from University of Sassari in Italy in 2012. Following that, he did his Ilizarov Fellowship in limb reconstruction in the Mangione Hospital, Lecco, under Professor Maurizio Catani. He is also a delegate for Lombardy and member of the scientific committee of CIFE. Currently, he is working as a consultant orthopedic surgeon and limb lengthening and reconstruction surgeon at Mangione Hospital, Lecco, San Camillo Hospital, Milan, and Columbus Clinic Center in Milan. He has multiple published papers under his name, and one of the important ones are like elbow arthrodesis for post-traumatic sequelae, surgical tactics using the Ilizarov frame. It was published in the Journal of Shoulder and Elbow Surgery. Early experience of non-contact bridging periposteric plates in complex periposteric fractures of THR and TKR. He has attended more than 50 international orthopedic congresses as faculty. He has been a regular faculty of Asami, Portugal and Asami, Brazil. He has attended 4th, 5th and 6th Asami international congresses as a faculty. He also presented his papers on knee preservation surgeries and newer osteotomy techniques in ILLRS Miami. He is also a faculty of Smith and Nephew limb restoration courses. So I will ask Dr. Pili to share your screen and start your presentation.
The screen should be sharing.
Yeah.
Able to see the screen. So thank you very much, Dr. Mandal. It's a pleasure to have been invited to do this discussion with this renowned surgeon from India. And Dr. Sharma, thank you. Dr. Soni, thank you. And Hoda as well. Thank you very much. As I said, there is a very good connection between Italy and India for many reasons from that you know your former prime minister was born in Torino some time ago, and we feel very much connected with you. And I'm really proud of being invited to this discussion. Basically, we are talking today how to use the Ilizarov technique for treating bone loss, which I believe is really the most important task of an Ilizarov frame. You can do, we were discussing before, when you get a bone loss, which is fortunately is not extremely common, but it happens in our career. there are different ways of treating a bone loss, different techniques which are well published, known. Among them, there is the Ilizarov system, and I can tell that any orthopedic surgeon well trained in Ilizarov surgery can deal with a bone loss. It's always a difficult task, but each of these surgeons can do with the bone loss. So knowing this technique is very handful, and in these difficult cases can be the way to deal with these very difficult cases and to manage to restore the patient health. So basically, hold on. I usually try to divide bone loss in two big categories: is post-traumatic or surgical bone loss. Post-traumatic is a bone loss you get after trauma. You get your motorcycle accident. You have a very bad injury. Part of the bone is actually gone, is either left on the street, or sometimes is so unclear and unvital that has to be removed, or is so comminuted that doesn't even come to your theater room, this is a post-traumatic cause. Even shotgun injuries are this kind of injuries can be collected into this kind of category. While surgical bone loss is a different kind of bone loss, which you can get because of trauma. Obviously, you get a trauma, you get your patient in your theater, you see the X-ray, you think that they are all segments you're going to treat with your surgery. Looks like it's okay and just needs healing. Then you realize that this bone is not as good as you think. Maybe because there is some large periosteal stripping, and so you actually see that that fragment of bone is not going to survive this trauma. And in that case, you are into a junction. You are with your car in a junction, you have to decide, shall I remove this bone or shall I keep this bone? As we were talking not long ago with our colleagues before this conversation started, it's often it's difficult to choose whether to remove that bone or keep it. But when you start having some practice and some experience, you will go more and more to the removal part, as you know that if you don't remove enough or you don't remove at all, you might get a non-union or even an infected non-union. Same when you get these cases of neglected fractures, neglected open fracture, which you get maybe in some area where there is no way of having proper surgical procedures, maybe because they are far away from a hospital, or there is an hospital where there is no orthopedic facilities. In that case, again, you might get some bad non-union, or even infection over a fracture, and so an infected non-union. In those cases, we try and elicit our students and our fellows to remove the bone which looks unhealthy and which is likely to feed the infection, so that you can do through bone transport or other means of surgeries, which I'll show you during this presentation, how to reconstruct that bone that is missing. So basically, when you see that some bone is exposed, usually that bone is unhealthy, is not vital, and is very easy to get infected. Sometimes you get some open fracture where the bone is exposed for a short time, and there is not that much periosteal stripping, and we know that the bone can actually survive. So if we have some of this fracture experience will tell us which one is likely to heal and which one is not likely to heal. So we can decide whether we can make it a try and try to fix this kind of fractures, even if they have been little contaminated or there is some periosteal stripping, or if decide to remove it, making a bone loss. Obviously, immediate covering is compulsory. It means that you cannot leave some bone exposed without having some coverage. Obviously, it's better if we manage to cover it with the patient tissue without doing any kind of surgery to cover this bone. But it's important that this bone is well clean and covered with tissue, because it needs to be vital. It needs to get its blood supply and be covered with healthy tissue. Sometimes we ask the plastic surgeons to come and help us, and orthoplastics. In some kind of injuries, I believe they are very helpful. They can help us, but I believe that the person in charge of this kind of trauma should be the orthopedic surgeon, and should ask the plastic surgeon to help in some occasions. But the leading person in a team with this kind of trauma should still be the orthopedic surgeon, because we need to decide which one is going to be the treatment that might suit the best these patients, which treatment will give us the best chance. And we need to know that sometimes this kind of treatment might fail. And so we need to intervene in that case with a different kind of tactics and techniques and techniques. And as I said before, if you know the Ilizarov technique and bone transport, you almost always will get out of even quite large bone loss of or one of these post-traumatic situations. So if you delay covering, necrosis will come and you will get a dead bone. Dead bone is an unhealthy bone, which is an area which is likely to get infected. Minimal contamination can hit bone when it is not alive, while very difficult is not that easy for an infection to actually take place in a healthy bone. There are conditions where the infection comes from the blood supply. I've seen these cases, but in most of cases, the bone is, when it's healthy, is difficult to be hit by a serious infection. Usually after trauma, if the bone and the tissue around is very healthy, usually the bone is able to react and not get infected. So if it's been left exposed, the bone devitalizes very quickly, and then infection is very likely to occur. And infection means bone loss, because we need to remove the infection. So bone loss classification, it's been published by Professor Catani, my mentor, a long time ago. He's been using this technique already from the early 80s and published in 1985. And you can find them online. These publications and this way of treating this kind of injuries is still the basic concept, which you should keep in mind doing any other kind of bone loss surgeries. So keep also in mind this classification. It's very simple, and the good thing of this classification is that helps you deciding which treatment you can do. If you need to do which kind of treatment using an Ilizarov frame. If you can do a simple compression, if you need to do a bifocal treatment or trifocal treatment, or if you can accept some degree of shortening, or it leads you very well on deciding which kind of surgery you can apply on these injuries. So if you have a gap, a fracture with the shortening but no gap, you already know it will gonna lead you to decide, depending on the kind of patient, whether he needs a kind of treatment or a different kind of treatment. Same with there is a shortening with gap, is a type B3 in this case, and then it helps you to decide which kind of treatment you can do. This is another thing to keep in mind when you get this kind of injuries. Basically, in tibia and femur, lower limb, if you get more than 2 centimeters, I will say from 2 to 3 centimeters, you need to start thinking whether it's best for the patient to have his leg length restored. Obviously, I'm talking about an average patient. I mean, a patient in an adult patient with in his adult age. I'm not talking about elderly patients. In that case, you need to think about differently. You might accept even more than 2 centimeters, or if you are in some conditions in which you have to decide whether to have a perfect leg or no leg. In that case, you can accept more than even 3, 4, 5 centimeters, even more. I've had some cases where we had to accept even more than that leg discrepancy, and the patient was happy with his limb attached and was happy like this. Humerus is much more forgiving. You can accept up to 5, even more than 5 centimeters. The function-wise, shorter than 5 centimeters, the patient can start having some problems, but it's very forgiving. So sometimes we can accept even more than this shortening in the upper limb, in the humerus. From an aesthetic point of view, less than 4 centimeters is even difficult to see. So just ladies that might not like to have their upper limb shorter more than 4 centimeters, but men usually don't complain that much. And I will lead mainly thinking about function rather than aesthetic for the looks of the arm. Forearm is not that forgiving, unfortunately. Some discrepancy in length, especially for one or the other, talking about radius or ulna, is shortened, while the other bone is still the same, the proper length, can cause quite some difficulties depending where the loss is. We know sometimes we actually do excise some part of the forearm bone, like in ulna, when we have some pain in the distal part of the ulna. So we know that the function is very good in those cases also. And sometimes, like when doing Campanji technique, we know that there can be some bone loss in the mid, or mainly in the distal part of the ulna. So we know that has got a different way of treating, and we can treat them accordingly to our knowledge and capabilities. But bear in mind, very few centimeters can give quite a distress of forearm function, especially supination pronation. So contraindication, relative contraindication. If there is a tibia or femur limb length discrepancy less than 2 centimeters, we know that with a shoe lift, this patient can deal very well. In the humerus, less than 5 centimeters, the patient can do functionally very well. and in the forearm, less than 1-2 centimeters, depending on where it is the bone loss and the discrepancy, we can still accept. So what kind of external fixator we can use? You can use monolateral external fixator, circular traditional small wires external fixation, hybrid circular wires and pins external fixation, or hybrid X-fix with monolateral plus circular frame. We can use all of these systems. We know they have advantages and disadvantages. So I'm not that fast on which one should be the best. I'm very used to circular frames, and I believe when you know how to apply, you can do almost everything just with these frames. The small advantage that some of these frames can give you, maybe not that much, but depends obviously on the surgeon experience, and I leave the surgeon decide which is the best frame to use. We prefer a hybrid circular frame with wires and pins. We use very little wires as an external fixator has a life. The span life for an external fixator is quite known. If you have all ways of all means of fixation, like hydroxyapatites, sham pins, you know that your external fixator can last quite long. It can be even 1.5 years, 2 years. I've seen external fixator lasting even longer. But we need to keep in mind that as this span time gets, the frame becomes less stable, and this can go against your plan, and so make your life difficult, and maybe not get you to achieve the full goal, which is obviously consolidation, get the patient free of infection if there is an infection, correct the limb length discrepancy, and have a full and perfect axis. All these 4 goals has to be reached. Sometimes we need to understand that it's not possible to get all of them, so we might actually need to withdraw and decide that we cannot get all of them and accept what we get, but this is the goal we are looking at. So these are the advantages and disadvantages, which is stability, make a perfect correction, apply with application of hinges like in circular frames, and less problem with pin and wire loosening, depending on which means we have, if we have some kind of pins, and if we can, how we can make stable the frame. Obviously, making a frame stable, apart from the actual structure and pins we are using, is also the anatomy of the patient. Obviously, an injury very close to a joint makes your life more difficult. In this case, always think if it's worth spanning the joint so that you might get more stability, which will help you getting out of your problem earlier rather than later. And so always think if you need stability, just span the joint and go for a distal tibia through the foot, or for a very proximal tibia to the femur, and the opposite if this distal femur spanning to the knee. Disadvantages of an external fixator: patient discomfort, difficult to apply. Sure, this can be something putting off our junior doctors to apply a circular frame, but is worth learning a new technique and how to make it perfect, or at least as good as possible, in order to get good result with that, as I said in a previous conversation, can get you with a very high result of consolidation and achievement of your goals. So what's the current strategy? If we have a bone loss, we have different kind of strategies. Vascularized bone transport, fibula, ribs, iliac crest. I would say rather vascular bone grafting. We can use all these kind of helps in having the orthoplastics helping us. They can help us in to do this kind of techniques. I believe sometimes it's good to have this kind of technique available. But remember that if you are an Ilizarov surgeon, you can do and deal with almost everything, even without having to do this kind of surgery. No vascularized fibula or bone grafts. Again, sometime you might need to do this kind of surgery, especially if you don't have some kind of facilities. To be honest, I'm not very much of a fan of this kind of surgery, as I've seen many complications. So unless you are not familiar at all with Ilizarov surgery and internal fixation, I will not elicit using this kind of surgery, apart from some kind of cases, as we said, like in a very young patient, tumors and this kind of bone loss in young patients. Allograft, I'm not a fan at all of allograft. I've seen very big complications, so I will leave it at really one of the last way of treating a bone loss. And obviously, if there is a very small bone loss, I know I'm really much of a fan of allograft. Synthetic ceramic growth factors. I don't know. Maybe if you have some kind of patient where you are aiming for a life expectancy, very short life expectancy, and you want to correct quickly that bone defect, you could use them, but the level of complication and the degree of this patient having a full consolidated limb at a few years from follow-up is not great, so we'll leave it to some selected cases. Muscular technique, many of our colleagues are very much into fashion with the muscular techniques, but I've been thoroughly looking into publications and into literature. And as I said in previous conversations, it's muscular technique has in literature a result which is quite low. If we check real statistics which are matched to an Ilizarov frames, it goes to a maximum of 60-65% of success. And to be honest with you, I'm not really even convinced of this number, while we have much more success with an Ilizarov frame. So I will stick with what we do and do in bone transport. Possible complications in this kind of techniques is the donor side mobility in fibular transport, infection, peroneal nerve palsy, ankle instability. Infection, fracture, and union, and in allografts. No pathologic bone in muscular and not physiological bone and not real consolidation. Something that looks like it's bone in the X-ray, but it's actually not bone in reality, going to fatigue and problems in the future like stress fracture or even infection on a muscular. It can happen, especially if you are doing this procedure in a very young patient. Think twice. So what's the goals we are trying to achieve with when we have a patient with bone loss? We want consolidation after reconstructing the bone, alignment of the mechanical axis, limb length discrepancy correction, and infection control. If we have all these 4 goals reached, we have had a very good case to show to our friends, and the patient is very happy, and they might actually remember you as a very good doctor that made their life better. So this is a case of trifocal, which is to show what we can do with very large bone loss. This is a large gap or more than 10 centimeters treated with an Ilizarov frame with a trifocal transport on the same segment. and you see that we can reach and gain a very large amount of bone reconstruction. And in this case, we have a very good axis, and then we have a final result with consolidation, alignment of the mechanical axis, and limb length discrepancy correction, as well as infection control. So we have a happy patient and we have a good case to show. Similar, post-traumatic bone loss. So in the femur, we have this much bone loss, which when you go to theater, believe me, is going to be more than what you see. Possibly you have to cut even some centimeter here next to the spine. So we end up with more than 10 centimeter bone loss. Bone transport again, with a bifocal bone transport, docking site, and then you get a full consolidation. And we have the final result with consolidation, alignment of the mechanical axis, limb length discrepancy correction, and infection is gone. So you achieved a full clinical result. Patient is happy, and also we are happy, and we can show these cases to our colleagues. We can use different techniques. We can use a contralateral vascularized fibula plus homolateral fibula transport, because we had a serious bone loss, like in tumors or in large trauma. But the patient has to be very young to do this. You can stabilize this with a frame, and we can get actually a good limb reconstruction, and the patient will be able to have a good function, even though they have this reconstructed knee, which the youngest the patient, obviously, the better, as they can remodel and learn to use this new joint, which is not a real knee, but it's a remodeled knee, which people doing this kind of surgery for a pediatric patient and doing limb reconstruction in patient like this, or like in congenital limb deficiencies must have to deal with quite often, and these kind of results can be obtained. Infection on a fibular transfer. Okay, you can try. Our colleague tried doing this kind of procedure with the orthoplastics, but they didn't get a good result. So again, remove all the bone which is infected, start a bone transport, and then you can get again a full result with all the 4 tasks reached. So we got all our 4 goals: consolidation, alignment of the axis, limb length discrepancy correction, and infection control. This is another case treated with a sort of masquelé. So this is how the patient came to us, and removal of the bone obviously is compulsory. Then start a transport. This is at the time of the docking site. As you can see, there is invasination of the skin. So revision of the docking site with removal of the skin to correct the invasination. Sometimes you might have to create a deformity, much more rarely than usual, as if you are if you are careful when doing your revision, usually you have enough skin. Actually, you have an excess of skin, which you have to be careful to cut when doing this kind of revision. And then you have the final result when you have achieved all the goals. Again, another patient treated with an external fixator. So we actually achieved the goal, as there is a union, even though X-ray wise you can see the union, so it's good enough, but you didn't achieve all 4 goals. The mechanical axis is no good, limb length discrepancy is no good, and infection might be there, might be not, maybe not, but 2 of your goals have not been achieved. So revision Revision with the Ilizarov frame, where you can correct the remaining deformity, correct the equinus foot and limb length discrepancies. Okay, so we have no mechanical assist and no limb length discrepancy correction in the case, and we can correct it with this in this system, having final result with full consolidation, alignment, limb length discrepancy correction, and infection using an Ilizarov frame. So think always if we can do an operation for the patient, just one, and get the patient sorted. So sometimes it's better to revise them sooner rather than later with a circular frame in order to correct all this and reach the full 4 goals. So do the last operation first. It's not my sentence, it's Professor Catani's sentence, but I like it very much. I think it gets people to understand better. Simple fracture with no bone loss. And then what happens? Somebody puts some allograft and stuff, and it becomes an infected non-union needing surgical bone loss. So remove the bone loss, bifocal transport during the treatment, and again 4 goals: consolidation, alignment of the mechanical assist, limb length discrepancy correction, and infection. Got good function. Bone infection, again, remove the bone, trifocal transport, and all 4 goals have been achieved again: consolidation, alignment, limb length discrepancy, and infection control. Okay, so this is the final result. Again, an infection, remove the bone, same good result. Again, bone infection, bone loss, trifocal transport, docking and wound closure. Again, like before, invasination and needing a revision of the skin as well as the bone. And all 4 goals are achieved as final result. Humerus, we said we want to treat bone loss more than 5 centimeters usually. Between 3 and 5, I will think twice, 3 times. Usually try to put the patient off. Sometimes ladies will ask you anyway, so you can decide what to do. So always remember the basics, where to put your pins, and you need some experience to do upper limb, as it's not quite as a tibia is a different kind of surgery. Especially on the distal side, you need to be careful, but proximal side also. Usually we use just 2 pins, dorsihepatitis coated. They can get loose for sure, but they should be enough if you make your treatment not too long, to last too much. So this is an atrophic non-union. This is how we do the external fixator for a bone transport. And again, you can do a monofocal, and this is the result, final result with full function. Another monofocal transport, a monofocal treatment. And this is a very old lady that had this non-union. Is not a full bone loss, as the amount of bone loss was very little, considering that we have to remove just a couple of centimeters. So the function is very good, and this lady was very happy with his limb back. Consolidation after just 6 months. For those who like X-ray, you can see a huge calcification here, which was a large it's a large aneurysm, aortic aneurysm. So the anesthetist was not so keen on operating on this lady, and we did this with a simple block. So we managed to operate on this lady with a simple block, and she had a result, and she was very happy about this. 9 months later, this was the function. Bone loss on a floating elbow, more than 5 centimeters. So you need to do a bone transport. So osteotomy or corticotomy, whatever you want to call it. We actually call it osteotomy because the corticotomy is it's something difficult to actually get in real nature. We just call this an osteotomy with bone transport and managing to do the amount of bone or correcting the amount of bone. If there is an infection, you can get rid of the amount of bone. This is a trick that everybody doing this kind of surgery should learn, which is a simple temporary fixation, which helps you put in your wire in your external fixation, definitive external fixation in the right way in theater. Then you, in the same section in theater, remove this temporary fixation after you put your frame. So this is the patient, this is the case, and this is the final results. So, any questions?
Excellent talk.
Okay.
Thank you,
So
boss.
this is
Excellent presentation.
So before we start, this is a picture I'm very fond of with Dr. Mandal. We took in Lecco when he came to visit us for quite a long time, and this is the editor of team still now without Dr. Mandal.
Thank you.
Questions?
Bera sir, you want to ask any questions?
Okay, here they very nicely explained everything. Okay, so and the most important thing I told, if I have the injury in my leg, I would have go for Ilizarov. That
I would either. I would either.
that activity there, and he has shown excellent result. And Ilizarov can do the wonderful thing. We know.
Yes.
Thank you. Okay.
Yes. Thank you. Thank you. Completely.
Hello, sir.
Yes.
Uh, yes, I am Dr. Aniruddha. So I wanted to ask one question that what is your criteria for bifocal transport or trifocal transport?
Basically, what we have to think as an external fixator, Ilizarov surgeon, is how long will this frame has to be in place? As we know that in a tibia, a frame can survive being quite stable for around 1 year and a half. The treatment might last damn long, even longer. So if I have a large bone defect, more than 7-8 centimeters, and
Okay,
I have the possibility of doing a trifocal, I will actually consider it, because this will speed the process and make the time in the frame less, and putting us at less risk of having to revise the frame. Second, which is as important, sometimes you will see that this patient have had very much trauma. So even if you in the X-ray you see some clear bone, that bone might not be as vital as you believe. So if you do an osteotomy in that area, maybe you don't get a good regenerate. How many times you guys doing Ilizarov frame, you notice that even though you go slow, very slow, even 0.5, even less than that, even 0.3, 0.25, you get a better regenerate. If you have a trifocal, sometimes one of the regenerate goes well and the other one goes bad. So you can decide that one of the regenerate you can stop or go very slow, and the other one go at a different speed. So it gives you more option and takes you and gives you makes your life more likely to go well. It makes your surgery more likely to go well. If in doubt, do a trifocal. If you have space, you can do a trifocal. If it's not needed because you have less than 6 centimeters, I will not do a trifocal. I will go for a monofocal almost always.
Okay. Okay, sir. Thank you, sir. It was an excellent presentation.
Thank you.
Thank
Thank you
you.
very much.
I have a question. The temporary fixation in humerus, if you can elaborate how it is done.
And it's now this is one of the ways of doing it. You just take a simple bar or a flat bar, which is more stable. Apply 2 simple pins, even without pre-drilling, just some fast pins. Put in in this system with your assistant, you can make your humerus look good, fix everything, and then you have something easy to do. It's not a stable fixation. It's something that has to last as long as you put the proper external fixator on.
Okay.
And sometimes some of these pins can actually be useful, and you can actually connect them to the
Rings.
final frame. It's a very good trick, and should be remembered when doing this kind of surgery.
Dr. Pili, you showed the last case was humerus transport. Do you apply distal forearm ring also to stabilize the joint?
Sometimes we do. Sometimes depends on the stability. As I said at the beginning of the presentation. Thank you for this question, actually, Dr. Hoda. Sometimes if you think that your fixation is not stable enough, don't be worried about bridging the joint. Sometimes you can bridge the joint even with a non-rigid fixation, but with something which is pretty free. So the patient is able to move the joint, but you can improve the stability anyway. And if you have some problem, you can actually block the 2 frames and improve furthermore the stability. Because we always in a balance. If we know that if we stop a joint for a long time, the joint might lose function. But we know that if we don't get the fracture to heal, we might lose the whole limb sometimes, or maybe we lose the joint anyway. So if we have this possibility of bridging the joint, why not? If you think your stability, your fixation is not going to be enough, bridge the joint, especially in the foot. Very often we bridge the foot. It's almost standard in very distal tibial reconstruction to bridge the foot, the ankle joint, and include the foot in the frame. It's something that helps you having more stability and achieving your goal.
Sir, I have a question. First of all, congratulations for excellent presentation. And what is your protocol regarding bone grafting post large transport? Means how frequent you do offer bone grafting at the docking site?
Thank you very much for this question, Dr. Soni. This is an eternal debate.
Yes. Means
Eternal.
people are having polar opposite views on that. There are people who never do graft, and there are people who always do bone graft.
I know.
Yes.
I think Professor Catani says always graft. Always graft. I've actually seen the patient healing without grafting. But I have never, ever regretted doing a bone graft, while I've regretted many times not having
Not
done
doing.
Not excellent.
Because you start getting a loose frame. You start thinking troubles and things, and start thinking, why didn't I do it? Why didn't I? So just for the sake of me sleeping well, I most and more follow Professor Catania advice and bone graft almost every month.
Okay, sir. Thank you, sir. And sir, do you do transport over cable?
We do transport on cable. If you have some conditions, you might need to do transport on cable. If you have a very small fragment, less than 2 centimeters, it's very difficult to actually pin it. And in that case, you can do transport on cable. In my experience, fortunately, I had to do it a few times, but it's very handy in some situations. Obviously, it has to be planned well, because depending on where you put the cables, the amount of movement has to be calculated very well. And it's difficult, and it has to be planned well, but sometimes it's very handful, especially if you have bad skin, and you can actually protect your transport much better in this way. Yes, the answer is yes.
Yes.
Cable transport is something to know.
Thank you, sir.
Dr. Amar, what is your take in comparison with about the bone grafting versus non-grafting?
Sir, I usually don't do bone grafting in a fresh transport, means in a trauma, post-trauma. In recalcitrant infected non-union, I do bone graft at the docking site. Rationale behind not doing bone grafting would be that we have adequately refashioned bone ends, we have a stable frame, there's an increase in vascularity of limb segment, and patient is ambulatory. So docking is a day one of fracture union, and we may not put a graft and it should usually unite. If bone ends are not in proper position, or if there's other associated issues, say patient is smoker or alcoholic, or in scenario where you feel that this case is likely to go for delayed union, then I would like to put a bone graft. But if we consider hardly, I would be grafting 5 to 10% cases in a bone transport, large bone transport, defect more than 8 centimeter.
Yes, I think Dr. Soni, you got the point. You are very experienced in Ilizarov surgery, and I think this decision by very experienced surgeons can be still
Justified.
If you are a very young Ilizarov surgeon, I will elicit to do more rather than less, because it's difficult. And as you go with your practice, try and make a
Yes.
way to deal with this. I agree perfectly with you, Dr. Soni.
Thank you, sir. Sir, do you use any scoring system in taking decision regarding limb salvage versus amputation in a counseling?
Yeah, well, we don't have a scoring system which we do for all of them. I consider a good result when I get the 4 goals, the main 4 goals. Obviously, we need to check the joints as well, because it's important to try and save the joints. But I found very difficult to find a simple scoring system. I think we should think of this because the starting point is always different. So it's difficult. The scoring system we should use, if we one day will manage to agree on a scoring system, all of us, it should consider many things: the final result and the beginning of where we started from. These are something that has to go in the scoring, so it's very difficult to agree on well agreed with scoring system. But yes, I believe that at some point we will have to find a well established and agreed scoring system to understand where we are getting to. Yes.
I have a question, sir. What about the corticotomy? For a transport, you always do it on the first sitting, or sometimes you prefer to do it in a second sitting due to some infection, persistent infection, or something like that.
We almost always do the osteotomy at the same time of the first surgery. I remember very few cases where we had to do to postpone the osteotomy or corticotomy. I have to go very back in time to remember some case, and it was for some very funny reasons, like some unstable patient or something like that. But believe me, if you can and you have time, do the osteotomy, because your frame has a life which is short. So as soon as you start, you reach the goal. If you wait, the frame is already getting old and getting more, and being more likely to get loose at the moment you actually need it, because you need more stability at the end of the treatment rather than the beginning. So I will elicit again to do your osteotomy, corticotomy, whatever you call it, as soon as possible, possibly during the first surgery. And I would say you can do it almost always.
Dr. Joydeep, probably one of reason why sir is doing almost in every case on the same sitting is because he's opting for a plastic coverage before he's opts for Ilizarov. In the cases where you do a primary Ilizarov where soft tissues are not yet healed, in those scenarios you may opt for delayed corticotomy. And another scene is infection after infected non-union after intramedullary nail fixation. In that scenario, I would prefer to wait rather than to do it same stage, because if there is some issue with persistent infection, then if our corticotomy gets infected, then the prognosis would be very guarded.
Yeah, take your point. We don't do it. We usually do the osteotomy, start the transport, and when we get to the docking site, we do the revision, almost always, or I will say in this case it's always. So if there is still some infection, we remove it at that point. And we take, and as you said previously, we take the same occasion to make the axis perfect, to get everything, to find if there is if any of the pin are loose, and change the loose pin so that our fixation become more stable, and that it's a different strategy. I get your point, but we do a different strategy because we know we're gonna do the revision anyway.
I have this question, like, did you see any cases of infected regenerate?
I've seen just 2 cases of infected regenerate in my whole career, and they were people taking IV drugs. IV drugs, not other kind. At least this is my experience in Italy. Okay, I don't know. Different countries, I've heard some
colleagues
having different experiences, but this is my experience in Italy. I have
What
a patient after lengthening of a nail is not my patient, it's been a patient I actually inherited from colleagues, getting a full regenerate infection. So this is my only experience with a regenerate infection, these 3 patients. Dr. Soni?
One may not have a full-blown infection in a regenerate site, but a low-grade infection is one of cause for hypertrophic regenerate. So whenever you feel that there is a hypertrophic regenerate, you should always evaluate what are the mechanical issues and what are biological issue. And in that, what I feel it is, whenever someone has done a corticotomy post-infected nail removal at same sitting, then the regenerate quality is reasonably less good as compared to the delayed corticotomy, say. And we are not doing delay in a corticotomy, say, for a period of 6 weeks, 10 weeks, like that. We do delay for around 2 weeks, 3 weeks only.
2 to 3 weeks, yeah.
So that would not significantly means increase the external fixator index.
I take your point. It's a good point. I'll keep this in mind when I see some bad regenerate from now.
Yes.
But yes, the 2 cases I've actually seen, they were there were some infection which was obvious infection, where the actual infection took the whole regenerate away, it up the whole regenerate, and there was a sinus at the end. So it was obviously an infection in those cases. In those two cases, there were both people dealing with drugs and using drugs, injecting themselves drugs.
And what is the method of correctomy you prefer? Are it by drill bit, by giggly, or directly with the osteotome?
Again, it's another never-ending story. Which osteotomy to use? I believe every surgeon should use the osteotomy they are more comfortable with, and this is, I think, the final answer. But I think you should be able to use both the techniques. In the humerus, I don't use jiggly saw. Why? Maybe because I'm not brave enough. And because so far, touching wood, I've not had any serious complication from osteotomies. The risk of a multiple perforation osteotomy, which is the one we do instead of the
Freehand technique.
jiggly saw, can cause a secondary fracture, which sometimes you get a spiral fracture going through the pin and destabilizing completely your frame. So when you are doing this multiple perforation osteotomy, don't twist the bone at the end, and make sure you actually made enough holes before you hit it with your osteotome. The jiggly saw, we have done many studies, and in our studies there is no difference in time of healing. So I don't see why not to use a jiggly saw technique for those reasons. While I prefer a multiple perforation technique when I have to do a acute correction. Sometimes you have to do two osteotomies, a proximal one and a distal one, and we choose to do one of the two is acute, and the second one is with a slow correction. Therefore, the one we do, I have to do with the multiple perforation. I prefer to do it with multiple perforation because you create a sort of surface which is rough, and you can actually stock it in the right position, the one you want, do some compression, and it will become very stable. And this is mainly the reason, because I think I get more stability. Otherwise, I prefer a jiggly saw osteotomy.
Oh, I have been doing osteotomies with jiggly saw, sir. But the problem that I faced is like local made jiggly saws that are available to me. They are of very poor quality. And during the osteotomy, it usually breaks. Like almost 40 to 50% time it breaks. So passing the next jiggly saw through the same hole is quite
Impossible.
difficult.
If you
Yeah,
know how to do it, tell me, because I'd be happy to learn. When I get this problem, I do a perforation from the same incision, and I hit it with a osteotome.
Yeah.
Why I ask this question, Dr. Amar, you remember that we have been doing with multiple drill bits, but at Kurgan we saw they have been directly doing with the osteotome, increasing the surface area.
So my preference is whenever I do metaphyseal osteotomy, I will do with freehand technique. Whenever I do a trifocal osteosynthesis, where a diaphyseal osteotomy, I would use either a multiple drill hole technique or jiggly saw technique. But for metaphyseal, freehand technique works very well, and it doesn't cause much comminution unless your half pin is very near your osteotomy site. In that scenario, there are chances of propagating iatrogenic fracture to nearby pin site.
Yeah, that's the reason why I
Yes.
actually prefer jiggly saw in the metaphyseal bone, because I've had some fractures, and it's not nice because your external fixator becomes unstable and you have to implement the fixation, and it's not the best. And sometimes I've noticed this later rather than during the operation, causing problems. And more of it, you get. If you have to do a lengthening, you might get that the fragment, if you get like a sort of butterfly fragment, this might cause you trouble when doing the lengthening, because where the butterfly is usually pulls, and so you get a deformity at the opposite side of the butterfly. So usually I prefer jiggly saw in those cases also because of this, and I would rather use a jiggly saw. But basically, my technique is jiggly saw unless I am looking for an advantage in a different way, or in humerus where I'm too scared to use a jiggly saw.
There is a question in the message box. Joydeep, can you please read that?
I can't see it, sir.
The question is by Dr. Subrata. Is 3D printed modular processes can be replacement of Ilizarov in future? Dr. Pili.
Is
3D
it what?
printed models. Dr. Subrata has asked that can 3D printed models be a replacement to Ilizarov in future?
I think in pediatric, yes. I've seen some very complicated pediatric deformities that I need to have in my hand to understand. But the most of the even the most of these deformities are quite easy to be fit into a classification. So if you know well the classification, usually you manage to make them to make your surgery work, because you know what's the deformity which you are dealing with. But I believe in some cases where you don't understand exactly the deformity and stuff, you can actually do a 3D printing and simulate your frame, and this can actually happen to get to make your life easier. So yes, I would be curious about it, but don't know whether I will like be desperate if this technology will not be used. I don't know if you get my point.
Any more questions, Joydeep?
Sir, I'm good. Anyone from audience? Anyone wants to ask anything? All of the Aniruddha.
No more questions.
Basu sir.
Basu sir was there, but I think he's left.
Okay. Saurabh, you want to ask anything?
I want to ask one question, sir. When you are doing bifocal corticotomy, trifocal corticotomy,
Yes.
if the corticotomy goes well in a good healthy bone, so what will be your first rate of destruction in both sides?
0.75 in tibia. And femoral 0.75.
Okay. In both
We
sides?
always start 0.75.
Okay.
In tibia, never go faster. Never. Even if it looks there is lots of bone, we never go faster. In femur, you might need to go faster. If you after already, if it's gone already 1 month, 1.5 months, and you don't see a good regenerate, slow down. Sometimes even go back, and then do an accordion. Wait for 10 to 15 days, and then start at a lower rate until you find the perfect rate. And as I said, sometime in the trifocal, you see that one, you have to go faster than the other, and do accordingly with what you see in the X-rays.
And what kind of frames do you use for trifocal, like tandem trifocal, or you use single rods to connect all the rings?
4 rods for every ring, always 4 rods. It becomes quite busy, quite crowded frame.
Like it's modular or single rods connecting all 4 or 5 rings, whatever.
No. You can do it, but why would you? If you need to change a rod, if you need to do a modification, something, you'll be stuck. believe me, your fragment will never go straight like a laser. It will always go trying to recurvate because there is something that makes more likely to tilt. It always tries to tilt. So if you are using just one rod for each, your frame might look more skinny. But as soon as the fragment will start tilting, you are a bit in a difficult situation, and you might need to do something complicated to change and to fix this problem. So no, I will stock with using several struts. Rods.
Any question? Can we conclude, Dr. Joydeep?
No, sir, I don't have any questions, and no more questions on the comment box also.
Jain sir, permission? Sir, then sir, can we end, sir?
Yeah,
Yes.
your
Sounds
final
good.
comments?
Before vote of thanks by Jain sir, shall we just have 2 words from Bera sir?
Amshul.
I thank Dr. Pili, as well as our President, as well as Secretary Asami, as well as past Secretary. We at West Bengal are trying to form a body. Already we have formed in the last session. And Joydeep is doing wonderful. He has taken all the initiative, and with regular webinars, as well as the cadaveric workshop and other workshops, we are trying to organize it in this part of the world. Thank you, Dr. Pili. We'll have you in our other webinars, as well as some Asami, as well as WB sessions also.
Thank you, Bera. It's been a pleasure. Thank you, Dr. Mandal, for organizing all this. It's been great, and it's a pleasure. I see. I'm talking with very experienced surgeons. I can tell from the question, from the answers, and from everything. I'm very pleased. I really enjoyed this meeting today. I think I learned more than I thought in this meeting.
Thank
you, sir. Thank you, sir.
Jain sir. Yeah. Dr. Amar, Dr. Jain, any closing remarks?
Jain sir, please.
Amar is secretary. He has to take the lead.
Sir. So it was a great pleasure to have Dr. Daniel here, and we are happy and learned a lot from his talk, and we'll be happy to host him again in future in some of our events. And I thank West Bengal Association for hosting this and taking this initiative, and hopefully we'll be doing more such activity in future. And thank you, sir.
It was a pleasure.
Thank you.
Thank
Good night.
Thank you.
Good night.
Night.
Yeah.
Thank you. Good night.
Bye-bye.
Good night,
Rishi, can we stop?
everyone.
Good night.
Good night.
Oh, Joydeep. Good night. Thank you.
Good night, everyone.
Good night.
Good night, everybody.
Good night.
Rishi, can we stop live? Rishi, are you there?
Good night.
Good night,
Yeah,
sir.
good night. See you.
You can leave. I'll ask Rishi to end this. I'll just call Rishi. You can leave, sir.
I'll give you a call, sir, tonight.
Sure. Rishi, are you there? Rishi? Rishi has left. I'll just call Rishi to end the live.
Akanksha is also not there.
Yeah, she has left. Dr. Ravi is silent. We cannot see him. Hey, where are you? Rishi, can we stop live?
I was just listening.